Thank you all for joining us today. Dr. Kanjuja, do you mind kicking us off?
Yeah, and thank you for joining us on this seminar, Early Detection and Treatment of Colorectal Cancer. Speaking today are Dr. Jennifer Young and myself. And Dr. Young is going to start the presentation with a set of slides, and then we can have a discussion. I'll add finer points if need be. Should I talk about myself to you guys? I went to medical school at Grant Medical College in Mumbai, India. I did my residency at Mount Carmel Health Systems here in Columbus, Ohio. For 1 year, I was at Grant Medical Center doing my colorectal fellowship. And after that, I've stayed in those two hospitals practicing for my career here in Columbus, Ohio. Um, I'm about 40 years out after fellowship program, and I love to do what I do, which is colorectal surgery. That's it about me. Dr. Young, you want to say something about yourself?
Hi, good afternoon-ish, I guess, to everyone. Thank you for joining us today. My name is Jennifer Nguyen. I am originally from Minnesota, went to the University of Minnesota for medical school. I did my residency in general surgery at the University of Miami, and then I did my fellowship at Allegheny Health Consortium in Pittsburgh. I am currently board certified in general surgery as well as colorectal surgery. And I just joined the practice, and I'm really excited to be here and to help take care of the patients through the Mount Carmel Health System. So we're going to start with my presentation. Let's start with discussing colorectal cancer by the numbers. So colorectal cancer is, I know it says the fourth most diagnosed, but the most recent data says it's actually the third most diagnosed cancer in the United States at this time. And an individual person's lifetime risk of developing colorectal cancer is around 4%. It is the second leading cause of death in all of cancer-related deaths. And the mortality rate has actually been decreasing, which has been great, and it's likely due to screening and that we're catching it earlier. 1 in 3 people who should be screened are actually never screened for colon cancer. So what is colon cancer? This is a slide that kind of explains to you the progression of colon cancer. So you start out with a normal colon, and over time, your cells develop genetic mutations, and they begin to grow polyps, which are these growths that kind of lost the ability to know when to stop growing. So they have these polyps, and as time goes on over the next like 10 to 20 years, the polyps can keep gaining more mutations and ultimately become a cancer. It's unclear to us, it's not like a 1-year process. It usually happens over probably 5 to 10 to 20 years, somewhere in there, before it goes from a polyp to a cancer. So in regards to screening, the basics. So polyps occur in about 30% of men, so it's 1 in every 3 men, and 20% of women, so about 1 in every 5 women. The recommended screening age for colonoscopy is between the ages of 45 and 75 years old. And between the ages of 75 and 85, it's a conversation between you and your practitioner on whether or not it's worth continuing. If there's a strong family history of colorectal cancer or even other cancers, there's a history of advanced polyps in your family, or if you have a history of inflammatory bowel disease or other colonic or GI illnesses, screening may start earlier for you. And screening is really important because it helps to identify colorectal cancer early, which then helps to improve treatment outcomes, and it overall improves the survivability of colorectal cancers. And it can also help, screening can also help us identify these polyps and remove them, which then down the road then prevents the colon cancer from even forming. Just to give you an idea of the survivability rate on how, if we catch it early. So if you have stage 1 or stage 2, either colon or rectal cancers, which means that it's confined to just the colon or the rectum and hasn't spread to the lymph nodes or outside of, or more to other organs, the survivability in 5 years is about 90%, which is actually really high. But as you can see, it goes down with each stage. So stage 3 is around 70 to 75% for colon and rectal cancers. And when you get to stage 4, which means that it has spread to other organs, the survivability over 5 years is around 10 to 20%. There are a lot of screening options that are offered. Most recently, the FDA has approved blood-based screening tests. And how this works is that it looks for signs of colorectal cancer or precancerous polyps that are more advanced in the blood. If you were to have this, it's supposed to be every 3 years, but I think it's important to note that at this time, even though FDA has approved it, it's not part of the recommended screening guidelines. There are stool-based tests. So what this is that you put your stool onto a little card or you put it into a little bottle and you send it in, and they look for blood or cancer DNA within the stool itself. This is usually done every 1 to 3 years. The most common that we've been seeing for our patients has been the Cologuard test. But it's really important to note that these tests are not to be recommended for patients who are high risk of colorectal cancer. And so patients with family history, for example, should not be getting a Cologuard or these other tests. The pros of these stool-based screening tests is that there's no direct risk to the colon because we're not doing a procedure. There's no bowel prep or changes in your diet that you need to do. The sampling can be done at home, and it is overall less expensive than a colonoscopy for each individual time that you have to do it. The cons, though, are that it can miss many polyps and as well as some cancers, and we'll talk more about this later. It needs to be done every 1 to 3 years. It does have a high false positive rate, which means that it is more likely to come back positive and send you to a colonoscopy. And the cons is also, like I said, if it comes back positive, you do need to proceed to a colonoscopy. Another screening option is a colonoscopy, which is the gold standard to detect colorectal cancer. It is both preventative, which means that if we see polyps, we can remove it to prevent your cancer. It is diagnostic, so if you have other GI symptoms, such as ulcerative colitis, or even microscopic colitis because you're having a lot of diarrhea and so forth, the colonoscopy can help us identify that. And it is therapeutic, which means that at times we can also treat your symptoms or even treat the polyps that are found. It should be performed at least every 10 years, but depending on how many polyps you have or if you have a family history, you might have it done more frequently than that. And it can be offered to patients who are super high risk at colorectal cancer, a high risk of colorectal cancer. And from my standpoint, it's what should be recommended for patients who are high risk for colorectal cancer. The pros, it allows us to look at the whole colon. We can biopsy things that look abnormal. We can remove polyps, which then can help prevent or may prevent cancer. It can help identify other diseases. And it's done just once every 10 years if everything looks good and is normal. The downside, though, is that you do have to take a bowel prep, and there are some pre-procedure diet/medication changes that are needed. What I will say about the bowel prep is a lot of patients go in and they come into the office and they ask me if they have to do the 4 liters that traditionally are given. There are a lot of other options available now that are a lot less, that are a lot more easy to follow and to stay with. And that can be discussed in the office. It is also dependent on the insurance that you have. The cons are also that on a one-time basis, it does cost more than the other options. You will need to take time off work because you will be getting anesthesia for the procedure. So you have to take the day off work and somebody will have to be driving you there and driving you home. There is a small risk of bleeding, injury to the colon, and infection. So I found this chart and I thought that it's really nice because it shows you. So if you look to that left side, COL is a colonoscopy, and a colonoscopy detects about 95% of advanced polyps as well as 95% of cancers. If you go to the very right columns where it says fit DNA, that is the Cologuard. And if you can see, Cologuard will miss about 7 to 8% of colorectal cancers, and it misses about 60% or so of advanced polyps, which means that time frame where we could have intervened and removed that advanced polyp before it became a cancer, we've lost that ability using the Cologuard. So which test is the best one to choose? And I truly believe that the best test is the one that the patient is going to stick with. Non-colonoscopy options such as the Cologuard are really also good because they will help get patients who are scared of a colonoscopy or who never intended to get a colonoscopy. It will have a high positive rate, which means that they are more likely to get sent to a colonoscopy. But we have to keep in mind that it misses about 7% of colorectal cancers. So yeah, if you have questions, you should come, you're welcome to come and see us in the office and we're happy to talk about it. Otherwise, you can talk to your primary care doctors about it as well. And now I'll open up the board to any questions.
So before the questions come in, I'd like to add and say a few things. Thank you, Jennifer. That was very well done. I'd like to add that in the high risk group, people who've had polyps in the past or have had colon cancers in the past, and people who've had radiation to the abdomen are also considered high risk. And in these high risk patients, we do not recommend stool-based tests. We recommend a colonoscopy.
Thank you for clarifying that.
So while we are waiting for the questions, we can add a few more things to our presentation, Dr. Nguyen. So the American Cancer Society recommended strategies for screening. There are 3 stool tests, right, and 3 visual tests. And the stool test that is most popular right now is looking for blood, FIT, and the multi-targeted DNA products in the stool, which is Cologuard, which has become quite common. But colonoscopy still is the most common way of screening for colorectal cancer here. And Cologuard is bringing a lot of patients to colonoscopy, just like Dr. Nguyen had mentioned. But I do want to tell you that a positive Cologuard, I'm finding out, causes a lot of anxiety. And patients should be prepared for that. If you do a Cologuard and it comes back positive, it causes a lot of anxiety that we have to address in the care of the patient. Because scheduling a colonoscopy may take some time. And majority of them do not have cancer. Majority of them have either polyps or have nothing at all.
So I see some questions. The first one is how do we schedule a test? So a colonoscopy can be scheduled. I think the best way is to go to your primary care doctor and they can place the referral either to us or place a referral for a colonoscopy if you have concerns. Do you have anything to add to that, Dr. Kanjuja?
Yes. Colonoscopies are usually done in Columbus, Ohio by either physicians like us, we are colorectal surgeons, or by gastroenterologists. And since colonoscopy is now a approved screening tool, you don't necessarily need a prior approval from the primary care physician. So if you are having trouble getting your procedure scheduled, you can contact a gastroenterologist's office or a colorectal surgeon's office and ask for a screening colonoscopy.
All right. The next question is, how common are the risks that were mentioned for a colonoscopy?
Okay, may I elaborate on that?
Yes, please.
Okay, so I tell every patient of mine in the preoperative area, when I go in there to introduce myself as, hi, I'm Dr. Kanjuja, I'm going to be doing your colonoscopy today. I describe the colonoscopy, and then I ask them if they have any questions. And whether they ask me the risk or not, I make sure that I tell them the following 2 risks, which are very essential from my end, which is an injury to the colon, It's also called a perforation. And the perforation, I tell them, in my hand is less than 1 in 10,000 patients. So I've been practicing now for 40 years. I've had 3 perforations, and I do about 1,000 of these procedures in a year. So the incidence is less than 1 in 10,000 patients. The next complication I tell them is post-polypectomy bleeding. So if we find a polyp, and about 30% of men have polyps, 20% of women have polyps, actually, when we do the colonoscopies, our adenoma detection rate is much higher than that. The frequency of bleeding 2 or 3 days after a polyp is removed, and the bleeding is not minor, it is massive. It requires a visit to the emergency room. It requires intervention in the form of blood transfusions, IV fluids, and even a second procedure. That rate is 1 in 500 patients in my hands. That's what I tell them. 1 in 10,000 for perforations, 1 in 500 for post-polypectomy bleeding. I never do a procedure without telling them that. Dr. Young, you want to say?
No, I kind of stole your colonoscopy talk. I've been telling my patients the same thing because the risk is it exists, but it is very low. I know they sound like very scary risks when you come to get your colonoscopy and we read you all this doom and gloom stuff, but the risk is actually very low. If it was very high, we wouldn't be doing as many colonoscopies as we do a year and wouldn't be recommending it.
I'd like to add in the same discussion that almost all colonoscopies that we do these days, there's an anesthesia provider that is providing you with medication to sedate you, and that is usually called propofol, and that can cause complications as well, like gastroesophageal reflux and aspirations. So we make sure that you're not eating or drinking for about 4 hours before the procedure.
Yeah.
Then the anesthesia provider may also give you medications to dry your secretions in your pharynx, in your oral cavity, in your throat, etc., and give you a dryness of your mouth after the procedure.
Yeah, and let's just talk about the prep a little bit, because somebody did ask a question about that. So in regards to the prep for the colonoscopy, it depends on your insurance, what's covered. There are options that are no longer the 4 liters of Go Lightly, which historically has been given. They do offer pill forms, and there are also forms that I tend to give my patients, if possible, which are 2 small 300 milliliter bottles, about the size of maybe a cup and a half, which you then drink, and then you would drink whatever fluids you want after that. You have to drink 2 liters of whatever fluid that's not red and not purple, guys, after that. But there are a lot of other options that are available on the market now.
So since I have the luxury of being in practice for a long time, I want to add a few things. What's very critical in what Dr. Wynn just said is that you can drink whatever fluid you want after you take those 2 small bottles, and you need to take 2 liters. That's very important that you hydrate yourself, because if you do not hydrate yourself, you run the risk of a kidney failure. So you may take the smaller laxatives like Dr. Wynn mentioned, but it is exceedingly important to hydrate yourself with a lot of liquids, 2 liters at the very least.
Yeah, and then also how the prep works is like the extra fluid helps clean you out even better. So, how is the colonoscopy prep different when a patient is on GLP/GIP medications?
How is it different on a what now?
For patients who are on GLP-1 inhibitors?
Okay. I don't know of any difference. Do you?
No, there's no difference for the prep. What symptoms should you keep an eye out for besides blood in your stool that could be concerning for cancer?
You need to be very alarmed with blood in the stool. You don't need any other symptom to get you to be calm or anything. If you have blood in your stool, you need to see a doctor who will evaluate you and hopefully recommend a colonoscopy. In my practice now, regardless of the age of the patient, if the patient has bleeding, I recommend a colonoscopy. And once you have bleeding, the topic is not screening. is not a screening procedure. Colonoscopy becomes a diagnostic procedure, not a screening procedure if you're bleeding. If you have symptoms, it is not screening. And the worst form of bleeding is blood mixed with mucus and mixed with the stool. That's the worst form of bleeding. Anal bleeding, on the other hand, such as blood when you wipe yourself and you see blood on the tissue paper, that we call it anal bleeding, and the stool is normal color, is less onerous than blood mixed with the stools.
Yeah. And then the other symptoms that patients will come in with, sometimes that will send them to a colonoscopy, are a lot more generalized. That can be indicative of a lot of things like abdominal pain, feeling tired, not feeling as hungry. Anemia, even if you don't see blood in your stool, is another thing that should warrant consideration of a colonoscopy. So if you go to your doctor and your blood counts are on the lower side, you should be considered as well. Can you talk a little bit about diverticulosis and diverticulitis? What is the difference?
That's not really what we're talking about today, but we can certainly expand on that. So diverticulosis is a condition where the lining of the colon protrudes through the muscle wall of the colon and is usually seen on the left side of the colon. And this is quite common in countries that have low fiber diet, and usually the more industrialized, the more developed the countries, there's a higher rate of diverticulosis. Diverticulosis is exceedingly common in the US population. Diverticulitis, on the other hand, ITIS, on the other hand, is infection that sets in a diverticulum. And when you have diverticulitis, you have pain in your stomach, you have a change in your bowel habits, you may have fever, you may even have nausea and vomiting. It's like appendicitis, but on the left side, usually on the left side. So diverticulitis is a condition of infection, and diverticulitis happens rarely in patients with diverticulosis and usually treated with antibiotics, but diverticulosis does not require treatment.
Yeah. With irritable bowel syndrome and polyps in the past, how often do you recommend colonoscopy? And go ahead.
If patients have polyps in the past?
Irritable bowel syndrome and polyps in the past.
Okay, irritable bowel syndrome is not an indication for colonoscopy, but polyps are an indication for colonoscopy. And depending on the number and size of the polyps, we determine the interval for colonoscopy. So if you've had one or two small polyps, by small polyps, I mean less than 10 millimeters, which is less than 2/5 of an inch, then we recommend a colonoscopy in 5 years. But if you have polyps that are 10 millimeters or more, or if you have 3 or more, we recommend a colonoscopy in 3 years. That's called the interval. However, if you had a very large polyp and we had to cut the polyp out in pieces, even though it's out completely, we have to repeat the colonoscopy within 3 to 6 months to make sure that large polyp is removed. If you have 10 or more polyps, the general recommendation is to repeat the colonoscopy in 1 year. This is opposed to if you did not have any polyps, and if you are an average risk patient, the next colonoscopy is 10 years.
Is colorectal cancer hereditary?
Absolutely, absolutely. There is sporadic cancers that are occurring without a family history, and then there's family history of colon cancers. There are some strong genetic syndromes that cause colon cancers, but luckily they are few and far between. Here in Columbus, Ohio, the incidence of the most commonly recognized hereditary colon cancer syndrome called HNPCC, also called Lynch syndrome in the past, and the terminology keep changing between Lynch and HNPCC, is around 2%, very low. And then there's a family history where people make hundreds of polyps called FAP, or familial polyposis syndrome, and that is less than 1%. Majority of the hereditary colon cancers occur in what we call family cancer syndrome, where you have 1 or 2 first-degree relatives with colon cancers, and that makes up around about 10 to 20%. But the majority, about 75%, are sporadic cancers, no family history of colon cancer whatsoever, and no history of inflammatory bowel disease like Crohn's disease or ulcerative colitis, and no history of radiation.
Is it painful to have polyps removed? Typically, it is not painful to have the polyps removed. The colonic lining, when we remove it, it doesn't really have any nerve sensors there, so you shouldn't feel anything. You might feel some crampiness from the gas, but not from the removal itself. If someone has a family history of GI cancer and a personal history of diverticulosis, how often should they get a scope, and is it safe while pregnant? I would not, just because we have to give anesthesia, recommend the colonoscopy to be done while you're pregnant, but we can do it after you're pregnant, unless you have some really concerning symptoms that we need you to get evaluated for immediately. In regards to diverticulosis, that doesn't mean that you need to get a screening more frequently, but the GI cancer family history part is concerning. So with the family history, it just depends on the age of diagnosis and how many family members who've had the GI cancer and what type of GI cancer it was, to make sure that it's not some sort of genetic component to it that might increase your risk for colon cancer. Let's see. Does the risk of cancer increase with age?
Yes. Colon polyps begin to appear in the 4th and 5th decade of life. And children, for example, do not have colon polyps. You know, the average person coming to a colonoscopy at age 45 or 50, men, 30% incidence of adenomas, and women around 20% incidence of adenomas. Children don't have that. So age is one of the most important factors of developing adenomas and colorectal cancer. So as you increase in age, the incidence of colon cancer comes up, and perhaps the peak age in the past used to be around 60 to 65. This keeps changing. Now we are having younger patients with colorectal cancer, younger than age 55. That is increasing more than the older age. So I don't know what the peak age is, but age is a very big factor in developing colorectal adenomas and colorectal cancer.
Yeah. I think this question is a good one. Is the shape of a patient's stool indicative of cancerous polyps, or of cancer or polyps, even without the presence of visible blood in the stool? So are there changes in stools that you should be concerned about?
Yes, if it's a fixed deformed stool which is thin, it may be indicative of a narrowing in the colon, and a narrowing in the colon on the left side of the colon may be indicative of a cancer if it's fixed. But if it fluctuates, it is not.
What dietary changes can reduce the risk of colorectal cancer?
What diet? Very good question. Best question asked so far. Diets that are rich in fiber, fruits, and vegetables, and are lacking in red meat and preservatives are safer than those mentioned otherwise. So the American Cancer Society recommends that in order to decrease the risk of colorectal cancer, you should decrease the consumption of red meat, processed meat, increase your contents of fruits and vegetables. Most importantly, alcohol is a high risk to develop any form of cancer. And then, of course, we should mention smoking as well. Should we hit the next thing as well, Dr. Nguyen, that increased activity has also shown to decrease colorectal cancer. So obesity is another risk factor for colorectal cancer.
And I think that's about all the time we have. There were some really great questions that were also asked. I'm sorry that we could not get to them today. But for the questions that you guys have, if we weren't able to get to them or answer them, you know, I would talk to your primary care physician to ask these questions or to schedule an appointment with us, and we're happy to discuss it with you.
Thank you so very much for your attention. And Dr. Nguyen, thank you very much for your presentation.
Yeah, thanks for having us, guys.